Oni Bojo Sego, this is Jody. Welcome back. This is Using Our Voice, a series of presentations about speaking up about unfair, poor care within the healthcare system and the harm that Indigenous people experience. This is our fourth module in the series. In this module, we're going to go over common stereotypes that surface within the healthcare system. So revisiting something that we introduced in earlier modules, this is the pathway to harm, and just going over it briefly, we start with colonial ideology. You'll sometimes hear me call these colonial narratives, and they're basically worldviews or how Indigenous people are viewed. Those worldviews, they transform into beliefs or stereotypes. Those stereotypes is what we're really going to dig into in this module. And the reason for that is, in my experience, if you're able to name the stereotype, it's a lot easier to interrupt the harm, which we're going to look at a little bit in depth in later module. So from the stereotype beliefs comes the prejudice or the attitudes. So these attitudes are patronizing, they're angry, hostile, they're contemptuous. So from these attitudes comes the behaviors or the actual discrimination that Indigenous people experience. And in the healthcare systems, that can show up as misdiagnosis, denial of care, avoiding Indigenous patients, ignoring them, labeling them, different things that we'll look at. So we're going to center our discussion around the stereotype part of this pathway to harm, and I'm going to give you some examples of what may indicate prejudice or discrimination associated with each of those stereotypes and the different forms of racism. So the pathway to harm, if you remember me referencing the work of Dr. Janet Smiley in First People, Second Class Treatment, there's clear connections made between the racism within the healthcare system and these outcomes for Indigenous patients. The outcomes would be lack of assessment, so not even being seen or triaged, so not getting any type of assessment, misdiagnosis. So the diagnosis for their symptoms is incorrect, often with drastic results, a lack of treatment, and a serious outcome of death. And you've seen that we introduced in our first module with the cases of Brian Sinclair and Joyce Echequan and Heather Winterstein. So the hope is that when you're able to see the different components of this pathway to harm, or you're able to see these outcomes, they're going to inform each other. So seeing the components of the pathway to harm, you're going to be on the lookout for the outcomes. Seeing the outcomes show up in that relationship or that service delivery, it's going to trigger you to look to see if there's the influence of bias, stereotype, prejudice, or discrimination. So just a review from what we covered in the previous module. These are the common stereotypes that show up within healthcare. So Indigenous patients are less worthy of care, they're drinkers, alcoholics, they're drug seeking, they're bad parents, they're frequent flyers, they're irresponsible and non-compliant, they're less capable and unfairly advantaged. So all of these are coming from the work done by the report In Plain Sight that happened in BC a few years ago. This is not the only report that's looked at common stereotypes about Indigenous people within the healthcare system, but yeah, it's one that we're going to be building on today. So the stereotype that Indigenous people are less worthy of care. So you remember in the first module, we talked about the roots of racism towards Indigenous people and how those early government documents, they described Indigenous people as incapable, inferior, childlike. So a lot of those beliefs about Indigenous people have carried on and they persist today. This idea that Indigenous patients are less worthy of care surfaces often within the healthcare system. So we're going to look at this slide, we're going to look at systemic and interpersonal. I want to say that these examples that I'm putting in these categories, they're not the entire list. They're only a highlight of what you might see. And the whole idea is to get you thinking about what you see in your interactions with the healthcare professionals and in those healthcare spaces, and get you thinking about, does this fit? Would this treatment fit if this person had this belief that I was less worthy of care? And that type of reflection and that type of, critical thinking, that analysis that you may go through, looking at what you're seeing, what you're experiencing, it can help you use this language that I'm presenting here, in particular naming these specific stereotypes when you're bringing attention to your patient experience. So we're going to go fairly quickly through these different components, and what I want to do is give you examples of how this stereotype would look like in those different forms of racism that we talked about. So we talked about systemic, we talked about epistemic, we talked about interpersonal, and we talked about internalized. I've grouped systemic and interpersonal together on the slides here, mostly because we're going to dig into them a little bit deeper in the next module with some very specific examples coming from the inquest into Joyce Echaquan's death. So you'll see there's a little bit different ordering here, and that's the reason for that. So less worthy of care. Indigenous people are not worthy. If you remember back when we introduced this, it was not worthy as compared to non-Indigenous people, and even less worthy when compared with white people. So what we see at systemic levels, so what would constitute systemic racism, is unequal funding. So there's fewer programs or services allocated towards to Indigenous people and communities, or they're lower quality. So Indigenous communities are often having to make do with less funding than non-Indigenous counterparts. So organizations that are delivering the same type of care but are non-Indigenous, off-reserve perhaps, they typically receive higher levels of funding than Indigenous specific or Indigenous-led organizations. Another thing that we see at that systemic level is lumping Indigenous people within DEI initiatives. So DEI is diversity, equity, and inclusion, and it's usually, those things that are advocating for a more diverse race workforce. Really creating space and acknowledging those cultural differences that exist within our society. We could argue that that's not distinctions-based because Indigenous people are not the same as Chinese people. They're not the same as Black people. They're not the same. We don't have the same experiences as other racialized groups within this society. And the reason for that, the reason why we ask for distinctions-based care or consideration is because we have inherent rights. So the Constitution, UNDRIP, we have legislation that says Indigenous people are to be supported in practicing their traditional ways, and that's recognizing that we were here prior to Canada. We were here prior to this whole multicultural nation that has emerged. When we look at why we may use the terms Indigenous and settler, even white people being considered as settlers, because it's going again back to the relationship to the land prior to colonization. So prior to colonization, Indigenous people were here, they were thriving, they were practicing their own ways of maintaining individual health and well-being, and distinction-based approaches honors that. So that's why, lumping Indigenous people into DEI initiatives or saying they're the same as, the considerations we may show for Black patients or for, South Asian patients, whatever it might be, is not it's not appropriate. It's not redressing the inequities. And think back to what we learned about Dr. Bryce, and under that definition of systemic racism, it's being aware that those inequities exist and the system doing nothing to redress those inequities or to reduce the harm that's coming from those inequities or to level the playing fields. So that's systemic racism. So one of the things I heard engaging with patient experiences departments is, oh, well, if we had to do this for every racial group, if we had to make space for every, ethnic group to bring in their medicines, to bring in their foods, to bring in, whatever it might be into these healthcare spaces, we would not, it would not be possible. So we can't do that. We have to treat everybody the same. That's not an approach that works for Indigenous people, and it really reinforces this idea that we're less worthy of care because we're denying that those inherent rights. Another way this may show up in systemic racism is that Indigenous people are not adequately represented nor supported within the workforce. Now, this could be at those leadership levels, so board of directors, those advisory groups where they have no Indigenous voices, or it could be within the actual staffing of the organization, so not reaching into Indigenous communities to promote job opportunities, and engage Indigenous people in applying and maintaining that employment. So putting the conditions in place to care for those Indigenous people in ways that make them, retained within that workforce. So for interpersonal, the stereotype of less worthy of care, you may see comments and like eye rolling or those microaggressions where they're kind of avoiding the Indigenous people. Like, what are they doing here? Putting the file at the bottom of the pile, calling up last. The size when they're engaging with Indigenous people, or the irritation in handing out resources. So there's been a feedback given by Indigenous patients, like it feels like they're handing me these resources out of their own pocket, like I'm not worthy of these bandages, or these services, these diagnostic tests. It's like pulling teeth. It's like I'm taking their own money away. That's some of the things that I've heard Indigenous people report on when they're feeling like they're less worthy of care. So staying with the stereotype less worthy of care, we have under epistemic rigid parameters around practices and policies. For example, standardized assessments, fixed appointment time limits. So no adjustments being made to, again, account for those things that separate Indigenous people from others. So we look at the earlier learning when we talked about Indian hospitals, and we talked about some of the neglect and the abuse and the things that happened for Indigenous people, like the experimentation, medical experimentation, the forced sterilization, different things that have happened. It's understandable why Indigenous people may have a distrust of medical systems and care providers. Again, looking back to, valuing what is knowledge. These standardized assessments, they're not valuing the same things that Indigenous people may find as valuable. These fixed appointment times, they're not valuing what Indigenous people may share about their holistic experience. So they're very rigid parameters around that engagement. And really and I've actually heard doctors say this to Indigenous patients, where, why do I need to know that? Like, let's just focus on, this. And I don't need to know what's happening with your marriage or with your housing situation. Like, this is all that I'm concerned about. So that's an example of epistemic racism that is guided by the stereotype of less worthy of care. And again, epistemic being valuing knowledge, so non-Indigenous knowledge, ways of being and doing over Indigenous. So Indigenous ways of being and doing and knowing seen as less valuable. There's no room for use of traditional medicines, practices, or ceremonies because they're viewed as primitive or pagan. And that could be something that's voiced directly, or it could be, indirectly with, kind of like those microaggressions we talked about, just kind of like a sigh or an eye roll. If a patient is wanting to share, oh, hey, I have this ceremony that I think would help, or I'd like to use these medicines. So that would be an example of the epistemic, less worthy of care. We don't value you as an Indigenous person, so we're not going to figure out how to make this happen for you to practice that ceremony, or to bring in those medicines. Less worthy of care. I've seen this a lot, internalized, and it could be patients are saying, maybe I don't really need this yet. Maybe I'm not sick enough. Delaying treatment because they're feeling like they somebody else out there deserves the resources more than they do. I can go without. They're really busy, so not valuing themselves, and in turn not engaging in ways that would take good care, that would not engaging in ways that would allow them the support, the resources to take good care of themselves. If that makes sense. Okay, this one, so the stereotype around drinking, alcoholics, a lot of these can be the same for the next one, which is drug seeking. So I've just put some highlights under each category here. So under systemic, I often seen policies, there's usually a paper put up next to registration desks or within waiting spaces, waiting rooms, that type of thing, where it says, this hospital has zero tolerance for aggressive behaviors or violence. Should you become aggressive or violent towards staff, you will be asked to leave, whatever. There's various ways in which that's worded. But what I've seen is that these stereotypes these policies were used as justification for removing Indigenous people from those spaces. So when we look at these policies, this is assuming that the behavior is drug induced. It's got to do with alcoholism. Oh, they're just drunk. So again, remember, systemic is looking at things that structure the system. So policies, practices, or even those informal workplace norms. This is just how things are done. So if we're going by the assumption or the belief that the Indigenous patient is a drinker or alcoholic, we're going to assume that the behavior is because they're drunk. The aggressive behavior is because they are drunk. So we may be asking them to leave under these policies. Asking in ways that can trigger defensiveness. So for some assessments, it's necessary for the healthcare professional to know whether or not there's alcohol in the system. It's really about how they ask that can indicate whether or not they're influenced by stereotypes. In some cases, it may not be that they're actively or aware that a stereotype is influencing how they're asking the question, but they're not really considering the impact. And there's a specific example here. So if somebody's coming to me and saying, how much have you had to drink today? They've made an assumption that I'm a drinker. They've made an assumption that I drink alcohol. I may not drink alcohol. I don't touch it. In fact, I haven't touched it in a very long time. So, I could become defensive because I'm like, why do you think I'm a drinker? So they may be asking that because that's just how they heard other people ask it. Another way to ask that question or to get that information would be without making that assumption. So it would be, rephrasing it. Do you drink alcohol? I'm asking because this information is important to this diagnosis, and, with that explanation. So, looking at the influence of that stereotype that Indigenous patients are drinkers and alcoholics, it can come across in how questions are asked, and really, being guided by the assumptions that they are active drinkers, they are alcoholics. So epistemic here is devaluing patient reports of symptoms and experiences, knowing that their experience is alcohol related. And I put in here substance related because it can be generalized too to other substances, not just alcohol. But the medical professional just saying, oh, I know what this is. I know that this person is a drinker, so I'm just going to assume that these symptoms are because they have consumed alcohol or they're in drug withdrawal. So really devaluing, not creating space to have that patient fulsomely share about their symptoms and experiences, and for those that information that's being shared to be really valued in terms of decisions around diagnosis and treatment. So drinkers and alcoholics, this is one that we're going to look at a little bit further ahead when we go into the inquest results for Joyce Echaquan. But it could be some comments for interpersonal racism. Comments could surface that suggest a person is a drinker or an alcoholic. They can be open, very clear, direct, and derogatory. All Native people are drunks. Or it could be more subtle things that you may hear if you're working within that system. You may hear colleagues say, oh, it's check day. We know it's going to be happening on the reserve tonight. Prepare for, a whole bunch of drunk Indians. So the first part would be subtle. We know what's happening in their communities today. The second part added to that makes it a little bit more openly racist. There's going to be a whole bunch of drunk Indians in here tonight. So, either way, both of those are indicating that stereotype that Indigenous patients are drinkers and alcoholics is having influence. One things that I've seen waiting in healthcare spaces with Indigenous patients is the staff would sometimes come out and give us the side eye. I don't know if you know what I mean when I say that, but looking out of the corner of their eye, a big round circle around us, but being kind of trying to be discreet, but because they're given the side eye, they're not being very discreet as they collect the hand sanitizers. So going around and kind of making it like this is something that they would normally do as part of their practice, but those sideline glances, indicating that they're only doing that because we're sitting in the waiting room. I've actually seen that happen on more than one occasion. So moving those drugs or hand sanitizers out of sight, out of reach. Drinkers and alcoholics, this can happen in not prescribing pain medication or other types of medication like anxiety medication, different things, because they have a belief that Indigenous people are going to be engaging in heavy alcohol use. So not even really exploring that alcohol use, just assuming that, oh, this person's a drinker, so we can't prescribe this to them because it's going to interact with the alcohol. So not even going down that route of considering, certain pain medications or other medications. Now, internalized, what I've seen with Indigenous patients is they are reluctant to share about their alcohol use. Maybe they are a high functioning, alcohol dependent where they're drinking alcohol. Maybe they're having wine every day at bedtime. But when they're being asked about it, they don't want to share because they're just going to think I'm fall down drunk. So there's no gray area in between. It's either, I don't drink and I'm good according to, what the healthcare system would define of me, or I drink and I'm seen as bad and a drunk. So there's no in between in that. There's no acceptable range in between there. So they're not going to speak about it at all because they want the healthcare professionals to think that they're going to be good patients and not make assumptions, erroneous assumptions about their alcohol use. They could be refusing pain medication because they themselves believe that they're more likely to become addicted. So this kind of ties along more along the lines of the drug seeking, but this is something that I put in here because it's the idea the beliefs or the colonial narratives that Indigenous people are susceptible to addiction. There's just something wrong with them. Remember, colonial ideologies are worldviews. So the worldview that connects to the stereotype that all Indigenous people are drinkers and alcoholics is that there's just something wrong with Indigenous people. They're just more likely to be addicted. There's something in their DNA that makes them addicts. So I have this piece in here about refusing pain medication because I've seen that in my own experiences where my mom was denying pain medication because she felt she was at a higher risk to become addicted. So she suffered with higher levels of pain because she didn't want to open up that door that she could become addicted, believing that that was a higher chance for her because she was Indigenous. Okay, so drug seeking kind of goes along the same lines. Again, it's Indigenous people are predisposed to substance dependence. That's the worldview or the ideology or the colonial narrative, something that has just been persisted, how Indigenous people are viewed, that's persisted over all of this time. The stereotype here is that Indigenous people are only engaging with the healthcare system because they want drugs. They want drugs to sell, they want drugs to get high, there's nothing wrong with them, they're only engaging with the healthcare system to get the drugs. So what you could see on a systemic level is practices or workplace norms that are influenced by this belief. So it could be I have here no further follow-up after drugs are provided. So there's no additional workups or connections that are made. This I've seen many times in personal experiences supporting loved ones with alcohol dependence. So going into emergency departments to get medical supervision during that withdrawal and detox. So if you don't know, alcohol withdrawal can be deadly. It can kill you. And a lot of times medication like the benzodiazepines or the benzos are required to calm the system down so that they're not going into seizures and they're not dying. So I've had instances where community members, Indigenous community members have engaged with the ER department and staff have said, oh, they're only here for benzos. They're only here for a prescription for benzos without acknowledging that the benzos can be life-saving medication. So the assumption there is that they're going to use those benzos, the lorazepam, the Ativan, whatever that they're asking for to calm their system down, that they're going to use them to get high, or they're going to use them to go out and to sell them. They're not actually going to use them to stabilize their system so they don't die. That's not an assumption that I've seen made a lot. But when it's influenced by that drug-seeking stereotype, those are the thoughts. So in those spaces, once the drugs are provided to stabilize that individual, immediately not being interested in doing any more investigation as to how that person can be helped. No referrals made to other supports. It's like they've got their drugs. We've done all that we can for them, that we're done with them. We wash our hands with them. We're done. We don't need to engage with them any further, right? So that's an influence of that drug-seeking stereotype. Epistemic, this really comes down to denying a patient's experience or minimizing the patient experience. So it could be things that are said to them like, oh, well, you're not in that much pain. Well, you can handle a little bit of pain, can't you? Not giving pain meds. So, if the tolerance has increased for a pain medication, just the medical professional is assuming that they're just wanting more to get that high feeling. And they're not really considering that the medication dosage isn't adequate. So they're trying to, we've seen this in cases where they're trying to extend the time between doses because they actually want to see for themselves that the patient is in pain. The patient reports of what they're experiencing, they're devaluing and they're dismissing. It's a very uncomfortable experience for anybody to be not believed when you're talking about your pain levels. I just want to put that out there because I've seen some Indigenous patients completely distraught because they are being denied this pain medication in timely fashions or in adequate dosages. So the interpersonal, the drug-seeking behaviors, the discrimination that we may see is similar to what we've already talked about in the drinkers and alcoholic stereotypes. And we're going to see this more detailed, more broke down in the next module when we take a look at Joyce Echaquan's inquest report. One of the things that they may start off with, so even as the medical professional comes into the room, they see the Indigenous patient, they may immediately say, we don't give prescriptions for drugs here. You can't get narcotics prescriptions here. As if, you know, to say that's the only reason that you're here. Okay, you can leave now because I'm going to tell you that's not happening. Okay, so it can be very direct like that. Internalized, it could be, you know, I don't want to ask for pain medication because they're going to think that I'm overusing it. They're going to think that I'm not in pain. They're going to think I'm you know, asking for this medication for reasons other than alleviating my pain. So they just won't ask. Okay, this one here, I've seen this often. I had some time working with Indigenous families with children 0 to 6, and with youngsters, you know, there's frequent interactions with the healthcare system. So the idea or the belief that Indigenous patients were bad parents was often surfacing, and it was surfacing frequently for younger parents. So, you know, late teens, early 20s, or for single parents, whether that be a single mom or a single dad. Seen this surface a lot. So under systemic, these are things that may not be happening so much. I believe most of the places, if not all, a number of years ago have discontinued this practice. But there was a practice across Canada in different provinces where birth alerts were issued for Indigenous people. And what these birth alerts were is they were put out by the Child Protection Agency, the Children's Aid Society, whatever, you know, organization it was in that child welfare system. They were alerts that were distributed to community partners like hospitals. I've seen them in the women's shelters that I worked in, various community organizations. The Children's Aid Society would blast out these communications and say, this individual, name, birth date, you know, location, whatever, is expecting to deliver a child around this time, so around August 2025. Should they deliver care or seek services from your organization for delivery, could you please contact and the Children's Aid Society. So these were blitzed out. They were often blitzed out without the patient's awareness. So what we often had happening is Indigenous women going in to deliver children, and within, you know, hours after birth, the Children's Aid Society showing up to open an investigation because the hospital was acting on a birth alert that they had received. So these were very horrific experiences for Indigenous parents. Like I said, they've been discontinued a number of years ago now in most places, but the memory of those birth alerts and those experiences, that stays alive and well in our communities. Another idea that speaks to healthcare professionals making the assumption that Indigenous patients are bad parents is automatically assuming that there's drinking or substance use during pregnancy, or, you know, inadequate care of the prenatal mom, the baby, you know, like just deliberate neglect, and yeah, deliberate neglect of the child. Epistemic, so this could be devaluing of parenting practices, ridiculing or not supporting things like returning the placenta to the family after birth, and not providing opportunity to use traditional medicines or practices, or not assigning any value to those traditional medicines or practices. I myself was one of those people that one of those people. I myself wanted to return the placenta of my children back to the earth. I never had any issues in asking for that, but I do know that when others that weren't supported, myself, I was supported by an Indigenous midwife, and in that process, a recognized healthcare provider in making that ask. I have heard of families that didn't have those connections, that just went into the hospitals and were asking and had to answer a lot of questions. Like, why would you want to do that? Why would you want that back? Oh, I guess I can ask. We don't get those kinds of requests, that type of thing. So really ridiculing and devaluing requests like that. Interpersonal, one of the things that I seen often was questions that don't relate to the medical condition of the child or the treatment plan of care for that patient. So really questioning around, how did this happen? Where were you when this happened? Was the child being supervised? Does this happen often? Type of thing. So questions that are really implying that there was neglect. This child's medical condition was a result of neglect, and it immediately puts Indigenous patients on the defensive and causes them to disengage, because when somebody is disapproving of you, you're very quick to pick that up, right? It's something that you know and you can feel. Comments can be made about lack of care, suggested neglect, and overly permissive parenting. Part of the colonial recordings or documentation from the earlier settlers commented on how our parenting practices were different from the settlers. And one of the ways that that's highlighted is how Indigenous people are believed to be overly permissive because we take an approach of teaching over punishment. Our practices are seen as just permissive and even neglectful. We're not teaching the child through discipline. So how is the child going to discipline themselves? So we're not, taking that punitive approach, which was considered as the best approach by settlers because that's how they do things. We were taking a different approach, and that approach was seen as less valued. So you may see some comments about, the eye rolling. One time I was in I was in a waiting room, and I had my children with me, and I had brought coloring books, and I had brought activities where we could sit there and we could engage while we were waiting. And one of the other people in the room had made a comment about, oh, children these days, they always need to be entertained. And like a comment like that where it's making judgment on how I was interacting with my children. It wasn't about entertaining my children. It was about spending quality time with my children while we had some time where we were forced to sit and be together. So it was me taking advantage of that time to really, read books to them and nurture our relationship and their curiosity, and how a settler, assumed I was entertaining them and how passed a negative judgment on me for doing that. So it may come up in issues like that. Internalized idea that Indigenous people are bad parents, and it could be parents are reluctant to seek care for their children. So this could be routine care like immunizations or checkups, or it could be urgent or emergency care because they fear that judgment that's coming from the healthcare professionals, and they fear that CAS involvement. So they're not wanting to engage. And that could be the reason why we see some things found at later stages of disease progression because of the unwillingness to engage. So this next one is frequent flyers. It's the belief that Indigenous patients are overusing or misusing the healthcare system, particularly the emergency department. How this may show up in systemic racism. It could be pulling up records from the past for inappropriate reasons. So healthcare professionals are not able to go into charts for no good reason. But if an individual is seen as a frequent flyer, they may be going back to say, oh, look, these are all the things that we've done, and they're not going to listen. they're just going to keep coming back. They don't really want help. They're not here for help because we recommended this, so many times before, and they didn't follow through. The idea is that when a patient presents themselves for care, you take a look at what is going on for them right there in that moment, and that is what you base decisions on. You don't base decisions on what they were presenting 6 months ago, what they were saying 6 months ago, that type of thing. Okay, the stereotype of frequent flyers, as it shows up with epistemic racism, it could be devaluing, not valuing what the patient has shared about their experience, really downplaying the severity of symptoms and sending them away. In interpersonal interactions, interpersonal racism, the frequent flyer stereotype may show up with healthcare professionals making assumptions about why the patient is there, using those assumptions to form opinions or diagnosis. It could be direct comments like, "So you're back again? Are you going to listen to us this time? They only wanted a ride into town." So implying that the use of the ambulance system is not justified. And for internalized, it could be Indigenous patients, saying things like, "I was just there and they didn't do anything." Remember, internalized racism is indicated by hopelessness. So it could be statements like, "There's no hope. I've been there so many times and it hasn't helped." So really feeling like they have misused the services. They've overused the services, and it's not appropriate for them to use them at this time because of that. Okay, so we continue with the irresponsible, non-compliant stereotype. This is a belief that Indigenous people are just not responsible to care for their health. They're not going to follow through with treatment plan recommendations like taking medication or keeping appointments. They're going to be non-compliant. Within systemic racism, what that looks like is going to the assumption that the patient cannot and will not follow treatment recommendations. So we talked about some of the harms Indigenous people have experienced within the healthcare system. A number of years ago, there was some research done on limb amputations within the Indigenous community, and it was found that doctors were jumping to recommend limb amputations rather than medication or other forms of treatment because they believed Indigenous patients would be non-compliant. They wouldn't follow through taking the medication as they needed or doing those other interventions as needed, so they were jumping ahead and going right to limb amputations. So that's an example of what systemic racism can look like, and influenced by that stereotype that Indigenous patients are going to be non-compliant. Epistemic racism, so this is again not valuing Indigenous knowledge, believing that the biomedical way of maintaining health and wellness is superior. So it's not creating space or listening to patient feedback on barriers that they may experience and following treatment plans. So rather than actually digging into why a patient may not be following through or why something may not be working for a patient, they're just going right to, well, they're irresponsible, they're just non-compliant. So there's no creating that space, no employing that curiosity to figure out what is actually happening with the Indigenous patient. Interpersonal racism, it could be condescending comments like, "Can you understand this? Do you know why this is important? Am I wasting my time telling you this?" So really tinged with that hostility that we talk about when we see prejudice. So that discrimination can come across in those microaggressions. In interpersonal interactions. So internalized, the stereotype, again, remember, internalized racism is characterized by hopelessness. It's not going to help anyway. Why should I? They don't care what I think. I told them what my issues are. It could be staying silent about barriers. So they may be talking to their loved ones at home or their family or their community about the barriers that they're facing, but they're not voicing those barriers to the healthcare professionals. They're not bringing them up as feedback on why this treatment plan isn't going to work, because they believe that there's no sense in doing that. It's not going to help anyway. Another way that this may show up is the Indigenous patient just going with the flow. So not really understanding the disease trajectory or the treatment, but just kind of going along, plodding along, doing as they're told without really understanding why. And again, it could be because they don't want to be seen as that difficult patient. You know, a lot of times Indigenous people are labeled as difficult patients, and coming to the healthcare providers in a vulnerable place where they're needing that support to be well, you want to be in their good graces, and you want to be that good patient. So you just go along with the flow without really understanding why. You don't want to voice that you need some clarification because you don't want to be judged as difficult or non-compliant. So this less capable, what this stereotype involves is the belief that Indigenous people just can't do it. They're just less capable. They're just not as good, to follow through or to do things as non-Indigenous, and particularly not as good as white. So what that can look like within systems, it could be more requirements to be met to qualify for funding, stricter reporting requirements. So often what happens is there's more hoops to jump through to obtain funding. So more arguments that you have to make, you have to provide more evidence. Once you get the funding, there's stricter reporting requirements. So organizations, Indigenous organizations, are asked to report more often. They're asked for more detailed reports than non-Indigenous organizations may have for the same programs and services. What that does is it really bogs down the administration and prevents them from engaging in other areas of the work. So it disadvantages them it really disadvantages them when compared to the operations of non-Indigenous led healthcare programs and services. Another thing that you may see is no consultation, shorter time frames. So, a health director being advised, oh, this funding is available, but you need to get your presentation or your proposal in by the end of the week type thing. And there's more constraints over what that funding can be used for. So say, for example, a non-Indigenous led clinic is getting a block of funding, and they're getting this block of funding for 5 years. And over the 5 years, there's no stipulations on how this funding is to be used. That non-Indigenous led organization has a greater degree of flexibility in designing programs and services to meet the needs of their community, whereas a similar organization within an Indigenous community is going to have more stipulations on what that funding can be used for, and it's going to be allocated for a shorter time. So rather than 5 years, this funding may only be available for 2 years, and there's going to be more, more requirements in the specific programs and services that can be provided for under this funding. And again, that's because that belief is there that Indigenous people just aren't capable of looking after themselves. Somebody else needs to come in and, help them out because they're childlike and they're incapable. Under epistemic racism here, I have white savior, and white savior, it's kind of building on that idea that Indigenous people aren't capable, but it's really, the non-Indigenous organization or leader or, institution, whatever it may be, coming in and saying, we know what's best for your community. This is the program and services that we've designed for your community. Here you go. So coming in with the the belief that we are less capable of taking care of our own needs, knowing what our own needs are and taking care of them and meeting them. And, they need to come in and save us. Within interpersonal interactions, this less capable can come across as talking down to a patient. So you're speaking with exaggerated slowness, or, like I'm speaking very slowly because I want you to understand what I'm saying. A different tone of voice. So raising the voice like the patient is deaf. Like, are you able to understand this? Did you hear what I said? Or, it could be speaking in a tone that's similar to what you would speak to like a child. Oh, are you sure you're understanding this? Do you need any more explanations? If you have any questions, speaking in a sing-song, very condescending type of way. Internalized Indigenous patients may have the belief that they're not smart enough to figure this out, like they aren't going to take any steps to, deepen their own understanding or advance their own learning about their disease or the treatment or anything, because they have this idea that they're not capable. They're not capable of figuring things out, and they're not speaking up. And again, that internalized racism is that hopelessness, right? So what does it matter? What does it matter? They're just going to do what they're going to do anyway. It doesn't matter what I say. So this not speaking up can be very problematic in instances like we've seen with Brian Sinclair. So trusting that the system is going to take care of them, when in fact the system has no vested interest in caring for them at all because of the influence of these stereotypes. So that's why, part of the reason why we really need to find our voice and encourage ourselves and each other to be speaking up. Now, this unfairly advantaged, it often comes from false ideas about what pays for Indigenous non-insured health benefits that are attached to status card. So status Indian registration that could cover like the prescription medication, the dental care, therapy, transportation for appointments. Sometimes it covers costs to come south. If you're in a northern community, you need to come down for procedures. Non-insured health benefits will cover that transportation, a portion of that transportation cost. So there's this idea that Indigenous people are unfairly advantaged. And what a lot of people don't know is that those benefits, we talked about the medicine chest clause in Treaty 6, those so-called benefits or advantages, they're actually coming from the government of Canada holding money, holding resources for Indigenous people from centuries ago, because of the belief that Indigenous people are not capable of handling money. So any transactions that were made for land or resources, the money would go into trust and the government would then dole out that money as it seemed fit. So those handouts are often seen as like those expenditures, or the money that's taken out of that, are seen as handouts when they're not handouts. So in systemic racism, you could see that as more stringent reporting requirements, when we talked about this earlier, higher thresholds to obtain funding or resources, and disputes over who is responsible. So disputes of, oh, is this a federal responsibility? Is this a provincial responsibility? So really not wanting to give Indigenous people more resources than what they're already getting, and being extra cautious that that's not happening. Epistemic, so I've seen this where in healthcare spaces where staff and other patients, non-Indigenous, were reporting that things like smudging within the healthcare space was a bother. It's inconveniencing others in hospital. They see that as an unfair advantage that Indigenous patients get within that system, and they can become quite irritated and angry because those allowances are made for Indigenous people. Interpersonal, there may be direct comments made like, oh, it must be nice to have everything paid for. Oh, so you're a nurse, you went through schooling with free tuition, must be nice. I had to take out student loans. Those types of comments between colleagues within Indigenous healthcare systems. Not wanting to provide resources at all, so not making referrals to certain resources, not distributing sample medication, believing that Indigenous people already take advantage of the system, so being very stingy with resources. Often what I have heard and what I've experienced myself is it's like the individual, even though they're using system resources that they're distributing, they're acting like that's money coming out of their own pocket. So if you see that type of behavior, and those attitudes that may come up like it's their money that they're handing out, that's a good indication that some of these stereotypes like Indigenous people are unfairly advantaged, are having some influence. For Indigenous patients, they may not want to be identified as a status card holder. They may not want to be identified as Indigenous because I guess that, again, this broader belief in society that Indigenous people are unfairly advantaged, and we want to avoid that type of labeling. So we're not going to be identifying ourselves as Indigenous. Okay, so we've gone over the common stereotypes and how they show up within healthcare spaces. What I want you to do with the remaining time that we have left is just think about which of these stereotypes have you seen in action? Have you seen them surface within your workplace, in media, so in news reports, movies, that type of thing, and across society in general? Ahead, what we're going to look at is how these stereotypes can contribute to harm to Indigenous patients, specifically looking at the inquest into Joyce Echaquan's death, in very specific examples of how these stereotypes surfaced and how we can interrupt that harm. So I'll leave this up here. This is the stereotypes that we covered today, and I'm just inviting you to think about where they may be showing up around you.